Vice Chairperson of Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.L. Swankar Sir, Chairman cum Councillor Dr. Vikas Chandra Swankar, Vice Chancellor Dr. Ajay Gulati, Pro-Vice Chancellor Dr. V.K. Kapoor, Principal of Mahatma Gandhi Medical College and Hospital Dr. N.D. Soni, Senior Faculty Members, colleagues and students. I welcome you all to the 20th undergraduate combined round of Mahatma Gandhi Medical College and Hospital. Today, the topic of UGCR is routine antenatal care, which will be covered by Department of Anatomy, Physiology, covering the vaccination, the imaging, safe prescription practices, and management of pregnancy. The chairpersons for today's session are Dr. Jaya Chaudhary, Professor and Unit Head from Department of Obstetrics and Gynaecology, Dr. Anusha Vora, Professor and Head of Department of Pharmacology, and Dr. Paresh Kumar Sukhani, Professor and Head Department of Radiology of Mahatma Gandhi University of Medical Sciences and Technology. As we commence this session, I invite Dr. Anshul Assistant Professor of Department of Obstetrics and Gynaecology, to brief us about what entails in routine antenatal care.
Thank you, Dr. Kritika. Good morning, respected dignitaries, my senior faculty, my colleagues, and my dear juniors. It is my utmost pleasure to welcome you all to today's UGCR, which is going to be an interdisciplinary academic session on pregnancy and routine antenatal care. Pregnancy is one of the most remarkable journeys of the life. It is a period filled with excitement, expectations, and sometimes uncertainties. Antenatal care plays a vital role in achieving a safe and healthy pregnancy. In today's UGCR, we bring together the combined expertise of 6 departments. The Department of Anatomy will help us understand the structural changes and the anatomical adaptations happening that supports the pregnancy. The Department of Physiology will take us through the dynamic physiological changes occurring during pregnancy. The Department of Community Medicine will highlight the importance of routine antenatal care at the population level, about the screening programs, maternal health services, nutrition and immunization. The Department of Pharmacology will address the safe and rational use of medications during pregnancy. The Department of Radiology will discuss the essential role of imaging and guiding us with the clinical decisions. And finally, the Department of Obstetrics and Gynaecology, will integrate all these concepts into clinical practice, covering routine antenatal visits, identification of high-risk pregnancies, management protocols, and preparing a woman for a safe delivery. By the end of this class, you should have a clearer understanding of how antenatal care contributes to a safer pregnancy, healthier babies, and better outcomes for the mother and the families. Thank you.
Good morning, students. I'll just take 2 minutes. Pregnancy, as has been already said, is a very important physiological state. And every young woman who is pregnant or who's expecting to become pregnant should know about it, what to do, what not to do. And every young man whose wife is going to be pregnant should know about it. So about 2-3 years ago, we started a program called Jaipur Swasthya Charcha, where we address the lay people about various aspects of health and disease. Because I feel that even highly educated and highly placed people in the society are medically illiterate. They don't know about health and disease. We've already done 60 sessions. A booklet of about 300 pages containing the summary of those sessions is already in the proof stage. It should be ready in a month or so. In that, there are 1 or 2 pages on pregnancy. But what I want, that the group of 30 students who have prepared for this UGCR, if you keep taking down notes in non-technical terms, simple English or English language addressed to lay people, that what are the various aspects of pregnancy which a lay person should know. And then, under the guidance of Dr. Jaya and other faculty from Gynaecology and Obstetrics, if you can produce a small booklet, we will get it published from the Jaipur Swasthya Charcha funds and distribute it for free to pregnant women who are coming to our hospital or other hospitals. It will also be useful for the paramedical staff, the nurses, the ANMs and the ASHA workers, So my request is that make use of this opportunity. All the students who contribute, they will find their names on the booklet, and it will be a good addition to your CV also. So I would request Dr. Jaya to see if the students can do this. Thank you.
Now, as we start the session, I would like to invite Rachit Gaur from Department of Anatomy to start the session.
Good morning, respected dignitaries, esteemed faculty members, seniors, fellow colleagues and dear juniors. We are representing the Department of Anatomy in the 20th undergraduate combined round on the topic Anatomical Changes During Pregnancy. This presentation is prepared by...
Why are you not mentioning the year of your admission?
So we were told that we shouldn't have to mention our batch.
Always mentioning like in which year you are?
2024. Second year.
You have passed first and year.
Yes. This presentation is prepared by Priyal Chaudhary,
Just hold on. So make it sure that everything they should write which year they are. It doesn't make any sense. Even second and year, first and year should have presented the NIT.
This presentation is prepared by Priyal Chaudhary, Neha Sharma, Purvanshi, Priyanshi Chaudhary and myself, Rachit Gaur, under the guidance of Dr. Pankaj Kumar Singh, Professor and Head, Department of Anatomy, and under the moderatorship of Dr. Rati Tandon, Associate Professor, Department of Anatomy. In this presentation, we will cover the key anatomical changes that occur as the maternal body adapts to nurture a new life. We will focus on the placenta, changes in the reproductive organs, in the mammary glands, and in the musculoskeletal system. What is pregnancy? Pregnancy is the period when a fertilized egg develops into an embryo and then a fetus inside the maternal uterus. It is a remarkable journey of growth and transformation. This slide reminds us of the starting point, the journey from a single cell to a successfully implanted embryo. The process begins with fertilization, where the sperm and the ovum unite, forming a zygote. This zygote immediately starts dividing through cleavage formation, forming the morula. The cells then undergo compaction, becoming tightly packed and form the blastocyst. The blastocyst burrows into the uterine wall in the process known as implantation. The placenta. The placenta is a unique, temporary feto-maternal organ. Anatomically, it is composed of two distinct parts. The fetal part, which develops from the chorionic sac. The maternal part, which is derived from the functional layer of the endometrium. Together with the umbilical cord, the placenta acts as the vital transport system for nutrients and oxygen between the mother and the fetus. The gross features. When looking at the gross anatomy of the full-term placenta, the two surfaces are distinct. The fetal surface, it is shiny, grey and translucent. It is smooth because it is covered by the amnion and it provides the attachment site for the umbilical cord. The maternal surface, it is dull red or maroon and has a rough texture. It presents a cobblestone-like appearance due to the presence of 15 to 20 cotyledons. Structure of placenta. The placenta has two components, the maternal components and the fetal components as discussed earlier. Now we'll discuss them in a little bit detail. The maternal components arise from the endometrium of uterus. It thickens and transforms into a specialized layer called the decidua. The decidua provides a supportive and nourishing environment for the implanted embryo. The decidua is categorized by decidua capsularis, which encloses and protects the developing embryo, decidua parietalis, which lines the remaining uterine cavity, the decidua basalis, which acts as the deep layer that joins with the embryo and forms the maternal side of the placenta. Fetal components. The fetal part originates from the trophoblast and extra-embryonic mesoderm, which combine to form the chorion. The chorionic levi is the smooth, non-functional part, whereas the chorionic frondosum is the functional part. It is formed by the villi towards the decidua basalis. The rest of the villi, which degenerate, form the chorionic levi. The chorionic villi from the fetus extend into the intervillous space, which is filled with maternal blood. The chorionic villi is of three types: primary, secondary and tertiary. The columns of syncytial trophoblastic trabeculae get penetrated by cytotrophoblast to form primary villi. Mesoderm enters the core of the primary villi to form secondary villi. Capillaries appear in the mesodermal core and the villi are called tertiary villi. Finally, the placenta is formed where the decidua basalis meets the chorionic frontosome. Placental barrier. It is a thin membrane separating the maternal blood from the fetal blood. It acts as a selective filter, allowing nutrients and IgG antibodies to pass while preventing the direct mixing of blood. During the initial stages of fetal development, placental barrier consists of syncytial trophoblast, cytotrophoblast, extraembryonic mesoderm, the basement membrane of endothelium, and the endothelium of fetal blood vessels. In later stages of pregnancy, cytotrophoblast and mesoderm becomes thin. So, the placental barrier is represented by a thin layer of syncytial trophoblast and fetal capillary endothelium. Changes in the reproductive system. The most dramatic change happens in the uterus. The non-pregnant women have a uterus which is a pelvic organ and weighs about 50 to 70 grams. Its shape is pear-shaped and its position is entirely pelvic. But in a pregnant woman, the uterus is an abdominopelvic organ which weighs about 900 to 1000 grams and it is globular in shape. Its position extends into the abdomen. Effect of hormones on the uterus. Increased vascularity. Blood vessels dilate and arteries remodel to provide low resistance to the increased blood flow to the uterus. Muscle fibers of myometrium undergo hypertrophy and hyperplasia to accommodate the growing fetus. Changes in cervix and vagina. We see two main changes here. Increased blood flow. The area around the vagina and the cervix gets much more vascular. This high vascularity causes them to develop a bluish discoloration, as you can see in the picture. Softening of the cervix. Increased vascularity and edema soften the cervix early in pregnancy. Changes in external genitalia. The external part of the reproductive system, the vulva, also becomes softer and more elastic, which is important for parturition. The labia majora might swell due to slower venous return and pigmentation often increases. The labia minora also becomes more hypertrophied. The growing fetus puts pressure on external genitalia, causing decreased venous return and edema. This sometimes leads to vulvar varicosities. Changes in mammary gland. The body begins preparing for breastfeeding long before birth. We see several key changes in the mammary gland. The mammary gland size increases due to glandular tissue growth. The areola enlarges and darkens visibly. The Montgomery tubercles become more prominent and the breast veins become more visible due to venous engorgement. Changes in the musculoskeletal system. As the uterus grows, the body's center of gravity shifts forward. To compensate and maintain balance, the curvature of the lumbar spine increases. This is known as lumbar lordosis. This mechanical shift, combined with hormonal joint laxity, often leads to the common complaint of lower back pain. Changes in muscles. The muscles of the trunk also adapt. The abdominal muscles stretch significantly. In some women, the two sides of the rectus abdominis may separate down the midline, as seen in the image. This is called diastasis recti. The pelvic floor muscles are also under constant strain from the weight of the growing uterus and fetus, often becoming weaker. Gait. Finally, the combined effect of the weight shift and joint relaxation changes how a pregnant woman walks. Her center of gravity, shifting forward, causes her to widen her stance to maintain stability. The increased lumbar lordosis and joint laxity can lead to a side-to-side hip sway, sometimes described as a waddling gait. This is natural adaptation to prevent falls. That concludes our overview of the amazing anatomical changes during pregnancy. It's an incredible process where the entire body adapts to support and grow a new life. Now I will hand over the mic to Parul Sonkaria from the Department of Physiology.
Good morning, dignitaries, esteemed faculty, colleagues, and juniors. We are representing the Department of Physiology in the 20th undergraduate combined round on the topic Physiological Changes During Normal Pregnancy. This presentation is prepared by one Manisha Goyal, Vanshita Agrawal, Yashashwini, Yuvika Yadav, and myself, Parul Sonkaria, of MBBS second year, under the guidance of Dr. Aparna Garg, Professor in Head Department of Physiology, and under the moderatorship of Dr. Shikha Mathur, Professor, Department of Physiology. Learning objectives. We will understand how pregnancy affects different systems of the body, including hematological, cardiovascular, gastrointestinal, respiratory, endocrine, renal, and skin and pigmentation. Starting with the introduction, what is pregnancy? It is the condition between conception and birth during which the fertilized egg develops in the uterus. The successful pregnancy results in the production of offspring, and it is typically lasts about 40 weeks from the last menstrual period and is divided into 3 stages: first trimester, second trimester, and the third trimester. This table shows the normal hematological reference ranges during different trimesters of the pregnancy. The hemoglobin and hematocrit gradually decrease from the baseline to the third trimester due to hemodilution, which means the dilution of the blood in the pregnancy. The plasma volume, which is liquid part of the blood, increase much more than the RBC, and due to this, the blood becomes more diluted. The WBC count increase, especially in the second and third trimester, showing the normal pregnancy-related leukocytosis. The platelets may slightly fall, but usually remain with the safe range. Cardiovascular changes are the blood volume increased by 30 to 50%, which provide the essential oxygen and nutrition to the growing fetus. Increased blood volume will lead to increase in heart rate by 10 to 20 beats per minute. And the decrease in blood pressure because the progesterone relaxes the blood vessel walls, which lowers the resistance. Hypercoagulability is due to increase in clotting factors to prevent excessive blood loss during the delivery. Gastrointestinal changes will include nausea and vomiting, which is caused mainly by the rise in HCG levels and the slow digestion. Food aversions are due to altered senses of smell and taste. The constipation, as progesterone relaxes the intestinal muscles, slowing the bowel movement. The pregnancy weight gain increase the trimester-wise. In the first and second trimester, it occurs mainly due to fat deposition. And in the third trimester, it is mainly due to increase in size of fetus and uterus. The total weight gain is about 11.5 to 16 kilograms in the pregnant female with a normal BMI. During pregnancy, the body shifts between 2 major metabolic phases, the anabolic and the catabolic. In anabolic phase, the mother body stores energy for the growing fetus, and there is increased food intake, enhanced lipid absorption, and the fat accumulation. The high estrogen and progesterone levels promote the nutrient storage, and this phase helps to build the maternal energy reserve. And simultaneously, in the catabolic phase, the body begins mobilizing the stored fats to supply energy to fetus. There is increased lipolysis, reduced lipoprotein lipase activity, and decreased the insulin sensitivity. Respiratory changes are the rising progesterone increases the mother respiratory drive, and the growing fetus pushes the diaphragm upward, making it more horizontal. These are the changes seen in the lung volume and capacities in a normal pregnant female. The slide shows how major pregnancy hormones changes across all the 3 trimesters and how these hormone shifts support the fetal growth, maternal adaptation, and the preparation for the labor. On the left side, we have a graph showing the level of key hormones: progesterone, estrogen, HCG, prolactin, oxytocin, and cortisol. And on the right side, the table summarizes how each hormone rises or stabilizes in each trimester. The progesterone continuously rises throughout the pregnancy with its peak in the third trimester, which helps to maintain the uterine lining, prevents contraction early on, and supports the fetal development. The HCG shows sharp peak in the first trimester, which is why the pregnancy test detected early, and after this the level drops and stabilizes later. The estrogen gradually increases and reaches its peak in the third trimester, which promotes the uterine growth, the increase in the blood flow, and prepare the body for labor. The prolactin gradually increases and reaches its peak in the third trimester, which prepare the breast for the lactation after delivery. The oxytocin level reaches its peak towards the end of the pregnancy, which play a crucial role in the initiating labor contraction, and later help with the milk lactation during breastfeeding. And the cortisol gradually increase and reaches its peak in the third trimester, which helps in the fetal lung maturation and increase maternal metabolism. Renal system also undergoes important adaptation like the dilatation of ureter due to progesterone relaxing smooth muscle, increased pressure on the bladder and ureter as the uterus grows, increase the bladder volume, increase in urine pH because of the bicarbonate changes. The reproductive changes in the breast. This enlargement is due to estrogen and progesterone. The areola becomes more darker and there is increased blood flow and the milk duct development. Changes in the cervix, which shows softening and increased vascularity. Changes in the uterus as it expands from the pelvic organ to the abdominal organ. To summarize, pregnancy affects nearly every organ system, all adapt to support fetal growth, prepare for delivery, and maintain the maternal homeostasis. These are the references. Now I would like to hand over the mic to the Department of Community Medicine.
Good morning, esteemed dignitaries, respected faculty members, and my fellow colleagues. Today, I am Manaswini Sharma, along with my group members Divya Yadav, Manan Keroriwal, Nandini Yadav, and Meha. I am here to present on the topic Immunization in Pregnancy. This presentation was formed under the guidance of Dr. Rachit Gaur, sir, Professor and Head of the Department Community Medicine, with the moderatorship of Dr. Indu Mohan ma'am and Dr. Tushar Kalra, sir. At the end of this session, we will be able to learn about maternal health, causes of death, ANC care, immunization, antenatal services, NFHS data comparison, and health programs and schemes. Let's start with maternal health. Immunization is an important preventive strategy to protect both mother and fetus from vaccine-preventable diseases. Mothers form a vulnerable group due to high morbidity and mortality, especially during pregnancy, childbirth, and postnatal period. Mother's health affects person from preconception, fetal, neonatal, infancy, and childhood to adulthood. This group constitutes about 24% of the population according to 2011 census. Causes of death. The major cause of death is hemorrhage, which constitutes about 37%, and the second major being the sepsis with 11%. Antenatal care. Antenatal care is a health care provided to mother during pregnancy. Its objectives are to promote and maintain physical, mental, and social health of the mother and baby. Second, to develop birth preparedness and complications readiness plan, and to help prepare mother to breastfeed successfully and explain her regarding normal and danger signs in the puerperal. Early registration. All the pregnancies should be registered as early as possible, ideally when woman recognizes she is pregnant and not later than the first trimester. A minimum of 4 healthcare checkups with the provision of services should be done. The first visit is recommended as early as possible and not later than the 12 weeks. The second visit between 14 and 26 weeks. The third visit between 28 and 34 weeks. And the fourth visit between 36 weeks and the term. Immunization. Some vaccines like tetanus, diphtheria, hepatitis B, influenza, and COVID-19 is given during pregnancy to protect the baby. Most important being tetanus, diphtheria, toxoid. According to National Immunization Schedule, the first dose of TB is given as early as possible and the second dose is given after the 4 weeks of the first dose. TD is tetanus plus diphtheria plus reduced dose of diphtheria toxoid. Previously, tetanus toxoid was given, which is now replaced by tetanus diphtheria toxoid as it gives better protection against both tetanus and diphtheria, as adult diphtheria immunity is low and thus helps in increasing population immunity and prevents adult diphtheria outbreak. Antenatal services. Services like iron and folic acid supplementation, calcium supplementation, immunization against tetanus and diphtheria, and dietary advice because there is an increased energy requirement of additional 350 calories during the pregnancy. Now here is the NFHS 5 data comparison with NFHS 4 data comparison. According to the indicators such as mothers who had ANC checkups in the first trimester and mothers who had at least 4 ANC visits has been increased over years. Mothers whose last birth was protected against neonatal tetanus has been increased from 89% to 92% and the vaccine coverage in Rajasthan from 81.9% to 93%. The incidences of the neonatal death has been decreased by 44% over the years due to some initiatives taken by the Government of India. These health programs and schemes includes Universal Immunization Program. This program is to decrease morbidity and mortality from 6 common vaccine preventable diseases in childhood and also to achieve self-sufficiency in the vaccine production. The second mission is Mission Indradhanush, to strengthen and re-energize the program and achieve full immunization coverage for all the children and pregnant women at a rapid pace. Government of India launched this mission in December 2014. The focus of this special drive was to improve immunization coverage in the districts and to ensure full immunization to more than 90% by December 2018. And next comes Ayushman Bharat program. This provides universal health coverage through Ayushman Arogya Mandir to provide preventive, promotive, curative, rehabilitative and palliative care. Its key components are health and wellness centers and Pradhan Mantri Jan Arogya Yojana. Pradhan Mantri Surachit Matritva Abhiyan. Its dedicated ANC day is 9th of every month. It is to reduce maternal and fetal mortality by ensuring quality antenatal care to all the pregnant women. Its key components are IEP-AN, that stands for Identification, Prompt Referral and Appropriate Management of High-Risk Pregnancies. The next is color coding, which indicates that the green for normal and the red for high-risk pregnancies. And voluntary participation from obstetricians, physicians and private doctors volunteer their services. SOMAN, that stands for Surakshit Matritva Ashwasan, focuses on assured delivery of the maternal and newborn health care services encompassing wider access to free and quality services, zero tolerance for the denial of services, assured management of complications, and respect for women's autonomy, dignity, feelings, choices, and preferences. It is to reduce maternal and neonatal mortality and promotes institutional delivery among the pregnant women. Institutional perinatal mortality has decreased from 35.8 per thousand live births to 14 per thousand live births in Rajasthan. Lastly, Pradhan Mantri Matru Vandana Yojana. Under this scheme, incentives are provided to pregnant women in 3 installments. First installment of ₹1,000 is given at the time of early registration. The second installment is given to the woman who has received at least 1 ANC at last. And last installment, that too of 2,000, is given when child has completed the first cycle of the immunization. These are the references. Now I would like to hand over the mic to the pharmacology department.
Good morning all. My name is Aniket Vyas and today I am going to present on the topic drugs and supplements used in pregnancy and their safe prescribing practices. This presentation is prepared by me, Aniket Vyas, Ayan Raj, Jasurani Pathak, Lavanya Shekhawat and Rachit Sharma. Under the guidance of Dr. Anusha Gora, Head of Department Pharmacology, and under the moderatorship of Dr. Rachit Mathur, Assistant Professor Pharmacology. A brief outline of what we will discuss in this presentation is as follows. Introduction, supplements, pharmacokinetics in pregnancy, choice of drugs for common problems during pregnancy, teratogenic drugs, FDA guidelines, safe prescribing practices, recent advances, and conclusion. Now, every time a pregnant woman takes a drug, she makes a decision that affects not only one, but 2 lives. So, our job as a doctor is to ensure that the safest possible therapy is provided to them. But the problem is that over 90% of approved drugs lack pharmacokinetic data in pregnant patients. Evidence shows that 79.62% of pregnant women consume prescription or over-the-counter medicines. This creates a dangerous situation as inappropriate usage of medications during pregnancy may result in adverse maternal and birth defects. While the drug-induced congenital anomalies are relatively uncommon, they are preventable. This makes rational prescribing in pregnancy very important. Now let's start with supplementation, which forms the foundation of safe pregnancy care. First trimester is the phase of fetal development and organogenesis. So the most crucial supplement is folic acid, which is given in the dosage of 400 micrograms to prevent neural tube defects such as spina bifida. In second trimester, iron and folic acid are given to prevent anemia. One tablet is given daily containing 60 milligrams of iron and 500 milligrams of folic acid. Calcium and vitamin D3 are given to prevent preeclampsia and to promote bone growth of the fetus. 2 tablets are given daily, each tablet containing 500 milligrams of calcium and 250 international units of vitamin D. Deworming tablets containing 400 milligrams of albendazole is given. Third trimester, iron and folic acid are continued 1 tablet per day to complete the 180 days course, and calcium and vitamin D3 are continued 2 tablets per day till 6 months postpartum. Now let's start with the precautions that we should keep in mind while giving these supplements. First, folic acid. Folic acid is safe in all 3 trimesters. High dose of folic acid should only be given if the patient has high risk, such as previous neural tube defects, epilepsy, diabetes, and obesity. We must avoid unnecessarily prolonged high doses in the post-first trimester unless it is indicated. Second, iron supplements. We must avoid giving iron along with coffee, tea, milk, or calcium because calcium reduces the absorption of iron. We must prefer giving iron empty stomach or with vitamin C. The side effects of giving iron are nausea, constipation, and black stools. We must not exceed 120 milligrams of iron per day unless there is severe anemia. And parenteral iron should only be given if oral iron is not tolerated or hemoglobin is less than 7 grams per deciliter. Third, calcium. Calcium should not be given with iron, and 2 to 3 hours of gap is mandatory between these 2 supplements. Excess calcium may cause kidney stones, constipation, or hypercalcemia. We must divide the dosage for better absorption. And an important point is that calcium should not be given an empty stomach as it may cause gastritis. Fourth, vitamin D. We must monitor the dosage of vitamin D if high dose therapy is given as it increases the risk of hypercalcemia. We must avoid mega doses unless there is deficiency documented. Now let's see the pharmacokinetic changes in pregnancy. First, absorption. There is decrease in gastric emptying due to increase in the levels of progesterone during pregnancy. This leads to delayed drug absorption and slower onset of action. Second, distribution. The volume of distribution increases by 40 to 50% in pregnancy, and the concentration of plasma albumin and other plasma proteins decreases. This leads to more free drug in circulation and increases the risk of toxicity. Third, metabolism. Due to progesterone and estrogen, the cytochrome P450 enzyme is altered. This leads to variable clearance and thus dose adjustment is needed. Fourth, excretion. There is increase in GFR by 50%. This leads to faster elimination of the drugs and thus there is need to increase the dosage. The choice of drugs for common problems during pregnancy depend upon these pharmacokinetic changes. For morning sickness and vomiting, promethazine, doxylamine, and dicyclomine are given. For headache and body pain, paracetamol is given. For hypertension, methyl-dopa, labetalol, nifedipine, and hydralazine are preferred. For allergy, chlorpheniramine is preferred. For diabetes, insulin is preferred. For constipation, dietary fibers, lactulose, and isagol are preferred. For thromboembolism, low molecular weight heparin is preferred. For epilepsy, lamotrigine is preferred. For systemic bacterial infections, erythromycin, cephalosporin, penicillin, and amoxicillin are preferred. Now, some drugs which are totally contraindicated during pregnancy are the teratogenic drugs because they cause structural and functional congenital anomalies if given during pregnancy, especially during the phase of organogenesis, which is 3 to 8 weeks. The teratogenic drugs are thalidomide, which causes phocomelia or limb defect, retinoids, which cause cleft palate, cardiac defects, and CNS anomalies, valproic acid, which causes neural tube defects such as spina bifida, carbamazepine, which causes neural tube defects and craniofacial defects, phenytoin, which causes fetal Haydn-Toyn syndrome, warfarin, which causes nasal hypoplasia and stipple epiphysis, methotrexate, which causes craniofacial defects and growth retardation, ACE inhibitors, which cause renal dysgenesis, and oligohydramnios, lithium, which causes Epstein's anomaly, misoprostol, which causes limb defects and Moebius syndrome, tetracyclines, which cause teeth discoloration and bone growth inhibition, aminoglycosides, which cause ototoxicity. Now the question arises, how do we systematically assess and communicate risk? For this, in 1979, FDA established a 5-letter risk categories, A, B, C, D, and X, to indicate the potential of a drug to cause birth defects if given during pregnancy. In 2015, a more clearer and detailed labeling was given to help the patients and doctors understand the drug risk better. This new rule was called as the Pregnancy and Lactation Labeling Final Rule, or PLLR. According to the old FDA guidelines, the drugs were categorized into 5 categories according to the studies done on humans and animals. The drugs in categories A and B, are the safe drugs because they show no fetal risk in control studies and human studies. The drugs in category C can only be used if the potential benefit outweighs the potential risk to the fetus, as there is no human study and fetal risk is shown in animal studies. And the drugs in the category D and X are totally contraindicated, as they show fetal risk in human studies. Now, according to the Pregnancy and Lactation Labeling Final Rule, PLLR, the information is divided into 3 categories. First, pregnancy, which includes pregnancy exposure registry, risk summary, data, and clinical considerations. Lactation includes risk summary, clinical considerations, and data. Female and males of reproductive potential includes pregnancy testing, contraception, and infertility. Now, some safe prescribing practices are: we must prescribe only standard guideline approved drugs and supplements according to the trimesters. We must strictly avoid teratogenic drugs, especially during the first trimester, which is the phase of organogenesis. We must use the lowest effective dose for the shortest necessary duration. We must maintain proper timing and spacing between the drugs. For example, iron and calcium should have 2 to 3 hours gap between their dosing. We must prefer single ingredient preparations over irrational multivitamin combinations, and regular monitoring of hemoglobin, blood pressure, blood sugar, and nutritional status is essential. Some recent advances to minimize the fetal exposure are: first, the placental drug delivery system, in which the drug is combined along with nanoparticle carriers and it is targeted directly to the placenta. This minimizes the drug exposure to the fetus and enhances the maternal efficacy. Second, the maternal fetal pharmacokinetic modeling, in which we use the patient-specific data and then mathematically predict the drug levels in the maternal and fetal compartment. This allows us to prescribe the most optimized dosing for the pregnant woman. Now, to conclude, we can ensure safe motherhood with evidence-based trimester-specific supplements and drug therapy. We can prevent harm by avoiding teratogenic drugs and irrational combinations. We must give emphasis upon correct dosing, timing, and adherence for optimal maternal nutrition and fetal development. And continuous monitoring and patient counseling are the pillars of effective antenatal care. Thank you. Now I would like to invite the radiology department.
Good morning, esteemed dignitaries, respected faculty members, and my fellow colleagues. I am Pranjal Mathur, along with the help of my group members, Neha Jain, Shaurya Lekra, Vinayak Onkarka, and Zainul Abidin Khan. I am here to present on the topic Imaging the Pregnancy. This presentation was formed under the guidance of Dr. Paresh Kumar Sukhani, Professor and Head of Department Radio Diagnosis, with the moderatorship of Dr. Priyanka Yadav, Assistant Professor, Department of Radio Diagnosis. We aim to fulfill the following objectives:
Importance of radiological imaging in pregnancy, antenatal sonography and its indications, PCPNDT Act and F-form, and understanding the role of MRI. Radiological imaging helps us in assessment of fetal growth and well-being, monitoring high-risk pregnancies and reducing maternal and fetal morbidity and mortality through early detection and management, diagnosis of obstetric emergencies and complications, and diagnosing fetal structural abnormalities and genetic syndromes. The modalities used include ultrasonography and MRI. Ultrasonography is the first-line imaging tool. It is safe, has no radiation, is easily available and cost-effective. MRI is the second-line modality and is used in inconclusive USG findings. They have no ionizing radiation and provide excellent soft tissue contrast. MR contrast is usually avoided. Radiography is also avoided. If clinically indicated, it can be done with lead apron shielding. The dose of standard radiograph is 0.1 milligrade, which is way below the permissible limit. To ensure legal compliance of radiodiagnostic techniques, PCPNDT Act was enforced. It stands for Preconception and Prenatal Diagnostic Techniques, and this act was passed in 1994. Its primary aim is to prevent female feticide. It helps regulate all prenatal diagnostic techniques like USG, amniocentesis, etc. Any communication of the sex of the fetus is a cognizable non-bailable offence. Mandatory compliance for every scan includes valid registration, registered qualified professionals, public display of signboard, written consent, and F-form. The F-form must be completely filled before every prenatal ultrasound. It is a medical legal requirement in hospitals and reinforces safe imaging practices. Moving on to our most commonly used modality, ultrasound. In the first trimester, ultrasound confirms intrauterine pregnancy and rules out ectopic pregnancy. It confirms viability of fetus, detect number of fetuses, dating of pregnancy, and evaluate maternal factors like uterine structural anomalies and masses. These are the ultrasound images of first trimester. The first image shows a normal intrauterine gestational sac and yolk sac. Second image shows an extrauterine gestational sac with a ring of fire appearance adjacent to the ovary, suggestive of ectopic pregnancy. And the third image shows presence of both intrauterine and extrauterine G-sac, suggestive of ectopic pregnancy. This image shows twin pregnancy. Monochorionic monoamniotic twins have no intertwin membrane. Monochorionic diamniotic twins have a thin intertwin membrane with a T sign, whereas dichorionic diamniotic twins have a thick intertwin membrane with a lambda sign. Pregnancy markers on USG are seen as gestational sac is visible at 4 weeks of transvaginal ultrasound and 4 to 5 weeks of transabdominal ultrasound. Fetal pole and yolk sac is visible at 5 weeks of transvaginal ultrasound and at 6 to 7 weeks of transabdominal ultrasound. Fetal heartbeats are seen at 5.5 to 6 weeks of transvaginal ultrasound and 6.5 to 7 weeks of transabdominal ultrasound. And fetal spine followed by head and limbs is seen at 8 to 9 weeks of transvaginal ultrasound and at 9 to 10 weeks of transabdominal ultrasound. In case of pregnancy failure, the definitive criteria includes crown rump length of more than or equal to 7 mm with no fetal heart rate, mean sac diameter of more than or equal to 25 mm with no embryo, absence of embryo with cardiac activity after 2 weeks of a scan showing G-sac without yolk sac, and absence of embryo with cardiac activity after 11 days of a scan showing G-sac with yolk sac. Suggestive parameters of pregnancy failure include fetal pole with no fetal heart rate, mean sac diameter of 16 to 24 mm with no embryo, absence of embryo with heartbeat 7 to 10 days after ultrasound that showed gestational sac with yolk sac, absence of embryo for 6 weeks or longer after LMP, empty amnion, enlarged yolk sac, and small gestational sac in relation to the size of embryo. The next key assessment is the NT-NV scan, performed between 11 and 13 weeks, when the crown rump length is between 45 to 85 mm. It is done when the fetus is in neutral position, meaning the neck is neither hyperflexed nor hyperextended. The important soft markers we evaluate are presence and absence of nasal bone, measurement of nuchal translucency, tricuspid regurgitation, and ductus venosus flow. This is an image showing fetus in neutral position. with normal nasal bone and mucus translucency. The image below it shows increase in mucus translucency.
What do you mean by anti-NB scan? What is the meaning of full form of anti and full form of
Mucus
NB?
translucency and nasal bone.
Why are you not speaking it? And what does it signify?
Fetal development, normal fetal development.
नहीं जो anti-NB स्कैन करते हैं, anti स्कैन करते हैं, तो किसके लिए करते हैं? क्या चीज़ रूल आउट करते हैं?
So कोई भी abnormalities and anormalities like Down syndrome and chromosomes.
So we should say it is for Down syndrome.
In the second trimester, ultrasound can be used to evaluate fetal anatomy, like fetal head, face, limbs, and heart. We can do this at 18 to 22 weeks. We can also do uterine artery evaluation for the risk of preeclampsia. Like in this case, we can see the normal uterine Doppler compared to the abnormal uterine Doppler showing persistent early diastolic knots. Ultrasound in the third trimester is done for evaluation of fetal growth, to check for cord around the neck and fetal presentation, placental maturity and location, fetal well-being via biophysical profile, and amniotic fluid index measurement. The first image shows a condition called placenta previa, in which the placenta entirely covers the internal os. The second image shows measurement of amniotic fluid index in all four quadrants, measuring deepest cord-free vertical pockets. Biophysical profile is done in cases of low fetal movements, which includes 5 components: fetus breathing movement, gross fetus body movement, muscle tone, volume of amniotic fluid, and non-stress test. Now coming on to the role of MRI, it is primarily done for the placental assessment, mainly for placental excreta spectrum. MRI can also be done for fetal anatomical clarification and to look for maternal pelvic pathological conditions such as pelvic masses and fibrodegeneration. Image A shows placenta excreta, where we can see intraplacental bands with raised placental bed vascularity and thinned out myometry. Image B shows placenta percreta, where we can see loss of myometrial outline and the placenta is staying continuous with the anterior abdominal wall. Now I invite the Department of Gynaecology to carry the presentation forward.
इसमें ताली बजाने की क्या बात है? भाई
A very warm good morning to esteemed dignitaries, faculty members, my fellow colleagues and juniors. I am Mansi Mishra on the behalf of the Department of Obstetrics and Gynaecology. Will be presenting in 20th UGCR on the topic Management of Pregnancy with the help of my fellow batchmates Anmol Songra, Arvind Singh, Bhavya Chaudhary and Rishita Devan under the able moderation of Dr. Anshul Kulshresht Ma'am, Assistant Professor, Department of Obstetrics and Gynaecology, and under the esteemed guidance of Dr. Jaya Chaudhary Ma'am, Professor and Unit Head, Department of Obstetrics and Gynaecology. Starting with, antenatal care is systemic supervision of a woman during pregnancy. This includes careful history taking, thorough medical examination, and advice given to the pregnant woman. Aims of antenatal care would be to educate the mother about the physiology of pregnancy, to screen high-risk cases, to prevent and detect complication at their earliest, to reduce maternal, perinatal morbidity and mortality, and to ensure health of the mother and birth of a healthy child. Trimesters, the ideal duration of a pregnancy is around 40 weeks, that is 280 days. The third trimesters range as follows. The first trimester starts from the first day of the last menstrual period to 12 weeks 6 days. The second trimester starts from 13 weeks to 28 weeks 6 days. And the third trimester starts from 29 weeks to 40 weeks. The schedule for antenatal visits is as follows. The initial visit should be made as early in pregnancy as possible. Return visits are as follows. Once every month till 28 weeks. Once every 2 weeks till 36 weeks. Once every week till 40 weeks. Also, the WHO has introduced the latest in ANC guidelines in 2016, in which the term visit has been changed to contacts. Now, there are around 8 contacts ranging across the 3 trimesters. In first trimester, the first contact is at 12 weeks. The second trimester, the second and the third contact are at 20 and 26 weeks respectively. And in the third trimesters, we have 5 contacts spaced at an interval of 2 weeks each. The first antenatal visit, our aim would be to assess the health status of the mother and fetus, to obtain baseline information against the subsequent changes are assessed, to screen high-risk pregnancy and to formulate the plan of management. Following subsequently after the antenatal visit, we'll perform a very detailed, careful history-taking examination of the patient, which would start with the age, duration of marriage, religion, occupation, period of gestation, history of present pregnancy, any major or minor complaints if present, obstetric history, if there is a history of consanguineous marriage or details of previous pregnancies, past menstrual history, the duration of the cycle and regularity, also if the patient has been taking oral contraceptives, past history, medical and surgical, family history or personal history. Now we'll talk about the gravida para system. Gravida is the total number of times woman has conceived. Para is number of previous pregnancies that reached viable gestational age. Abortion is the number of losses in pregnancy that ended before viability. And live is the number of living children. We'll talk about the Negley's formula. Negley's formula is used to calculate the expected date of delivery. We'll add 9 calendar months from the first day of last period and then add 7 days to get expected date of delivery. This is the formula. Moving towards general physical examination, we'll first start with the vitals. We'll assess the pulse rate, blood pressure, respiratory rate, temperature, followed by asking the build of the patient, nutrition, weight, pallor, icterus, oral hygiene. In the neck, we'll look for thyroid or lymphadenopathy and we'll assess pedal edema. Followed by cystic examination, we have 3 systems broadly to examine: the cardiovascular, respiratory and the central nervous system. In the cardiovascular system, we'll look for engorgement of neck veins, any heart rate patterns, murmur. Diastolic murmur in pregnancy is often abnormal. In the respiratory system, we'll look for the breathing pattern, the respiratory rate and adventitious sounds. And in the central nervous system, we'll look for the gait, visual symptoms and any reflexes present. Here are some factors which lead to a high-risk pregnancy. First, we'll assess the fetal factors. If there is a restriction in the fetal growth, if there are any congenital anomalies present, if there is any chromosomal abnormalities present, and if there is any history of RH incompatibility. During maternal factors, if there is a medical history of hypertension, diabetes, any heart, renal disorders, thyroid disorders, epilepsy, followed by some demographic factors if the patient is ages less than 18 or more than 35 years, low socioeconomic status, short inter-pregnancy interval, followed by some lifestyle factors if the patient is alcoholic or smokes, any history of drug abuse and obesity. Also, obstetric factors would include previous preterm birth, previous cesarean section, recurrent pregnancy loss, or a placenta previa or abruptio. We'll move towards the trimester-wise management. In the first trimester, the classical symptoms is your amenorrhea, morning sickness, usually in 70% of the cases, breast discomfort, fatigue, and increased frequency of micturition. The routine investigations would be followed by ABO-RH serotyping, complete blood count, blood sugar level, urine routine microscopy, HIV, HbA-CG levels, VDRL test, and serum TSH. In the USG, we'll go for dating scan and the NT-NB scan. In the special test, we have the ICT test and dual marker test. And in treatment principles, we'll go for folic acid supplementation as per WHO 400 micrograms daily and doxylamine succinate for nausea and vomiting. In the second trimester, we'll assess chloasma. We'll look for chloasma, breast changes, enlargement of lower abdomen, and quickening. Our management principle would be first to monitor the weight, blood pressure, urine, albumin, and sugar in each visit, followed by iron, folic acid supplementation, and calcium supplementation in nutrition management, tetanus immunization, investigation with CDC, and gestational diabetes by the Dept test. Now we'll see what is the Dept test. Here in the pregnant woman, we'll conduct a test for gestational diabetes mellitus at the first antenatal visit, which is around 12 to 16 weeks. We'll give her 75. We'll conduct a 75-gram oral glucose test. If it is positive after 2 hours, that is, the level is more than 140 milligram per deciliter, we'll manage the gestational diabetes mellitus as per the guidelines. Whereas if it is negative, less than 140 milligram per deciliter after 2 hours, we'll first repeat the test at 24 to 28 weeks and again at 32 to 34 weeks in high-risk women. If it is again positive, then we'll manage the gestational diabetes mellitus as per the guidelines. And if it is again negative, then we'll manage as well normal ANC guidelines. In the third trimester, we will assess for daily fetal movement count, lightening, increased frequency of micturition and pedal edema. Now we'll come towards examination. The first step will follow is inspection. We'll look for linea nigra, which is a linear pigmented line extending from the pubic symphysis to the xiphisternum. We'll look for stria gravidarum, purple patches in the lower abdomen. And we'll also look for any injury marks or any scar in the abdomen. Like in this, we can see the Fanelstein scar as an example of lower cervical cesarean section. In obstetrics examination, we'll go for palpation. In fundal examination, this is used to assess the height of the fundus due to calculate the period of gestation. We'll also perform the 4 Leopold maneuvers to know the lie, position and presentation of the fetus in utero. In auscultation, we'll assess the fetal heart sound. This is the most conclusive sign of a pregnancy. This can be felt around the spino-umbilical line. In third trimester, our management principle would be to assess again weight, blood pressure, urine, albumin, sugar in each visit, followed by continuation iron, folic acid and calcium supplementation. We'll perform a complete blood count. We'll go for a USG and Doppler if indicated, non-stress test when indicated, childbirth education and discussing birth plan and contraceptive counseling. Now these are the warning signs. If a woman presents with any of these in any of the 3 trimesters, then she must report to the hospital. In the first trimester, it would be excessive vomiting, lower abdominal pain, vaginal bleeding. In the second trimester, it would be leaking per vagina, bleeding per vagina, pain in lower abdomen, sudden weight gain, edema of hands and feet. In the last trimester, it would be decreased absent fetal movements, leaking per vagina, again bleeding per vagina, labor pain, headache, blurring of vision, severe epigastric pain and convulsions. Thank you.